spine and start leukoporesis. Another oncology emergency is, which is the respiratory emergency. This mediastinal mass, super mediastinal mass, and syndrome. Okay, the mediastinal mass, this is are relatively common in children. It depends on the size, most commonly in the anterior mediastinum, where the patient has leukemia, non-Hodgkin lymphoma, or middle mediastinum, lymphoma, bronchogenic cyst, or posterior neuroblastoma, ganglion neuroblastoma, and paraspinal wing sarcoma, rhabdomyosarcoma. These are the ones. This is massive anterior mediastinum, can cause a life-threatening compromise in the airway and cardiovascular. If affected, it depends on the severity and the degree of displacement. If affects the structure like trachobronchial, this will airway compression, and heart and visit will affect the venous retain, different supraventricular syndrome, and so both supraventricular syndrome as well as supraventricular mass can rapidly progress airway obstruction, hypoxia, and hemodynamic stability, especially, and for special care to the patient if he's going for anesthesia or sedation. 75% of patients can present to some degree of respiratory distress, as subacute onset cough or history of aggressive airway. But the emergency here, sign of airway obstruction. If the patient presents with stridus, dyspnea, anxiety, and orthopnea or trap position, think about the mediastinal mass. Our patients have severe vena syndrome, facial and the neck swelling, plethora, distended physics. The hallmark, the child with suspected anterior mediastinal mass, respiratory compromise must be considered at high risk during sedation and anesthesia. These are the diagnoses by the imaging, definitive imaging, either chest X-ray, CT scan, tissue. You have to do biopsy and bone marrow aspiration, and if he has fusion, you can do pleural or pericardial effusion. Okay, the management position, keep the patient in semi-sitting, start IV fluid, like access IV access, you can put in the lower extremities. Okay, start hydration, medication, emergency, oxygen, you can get oxygen, you can get also Helix or helium oxygen. So the airway obstruction and cardiovascular collapse can occur suddenly with the position change, with change or sedation. Always maintain spontaneous breathing and upright posture. Management chemotherapy can start steroid. If the patient is really critical, can even give radiotherapy. Another oncology emergency, spinal cord compression, occurring 3 to 5% of pediatric. They can present at or before the diagnosis. If not detected, it can lead to irreversible spinal cord injury. This is the most cause of acute lower limb weakness and paralysis. Definite management, urgent multidisciplinary coordination, pediatric oncology, and neurosurgeon and radiation oncology. These are the sites where they can have cord compression. Okay, so the suspected patient with spinal cord compression, they can have persistent or worsening when lying down. Patients can have peripheral pain, nerve-related component, early symptoms of back pain, progressive finding, autonomic symptoms like urinary intention, incontinence or constipation, urgent action, immediate assessment of spinal cord, spinal MRI, and initiation of steroid to prevent irreversible paralysis. The management, so I will go to the brain tumor. الله يسامحكم الله 15 minutes ما تكفي. This is the most common solid tumor. بعدين into emergency. الحين you have to recognize this one. Yeah. So most common solid tumor. It is the second most common childhood malignancy after leukemia. It can occur at anywhere. The most common عندنا هو posterior fossa, medulloblastoma, astrocytoma, ependymoma. They have raised intracranial pressure, hydrocephalus, brain stem compression. Early recognition and urgent management are essential to prevent brain herniation and irreversible neurological abnormality. These are the clinical presentation: vomiting, edema, ataxia. The infant can have bulging continent, increase in head circumference, and the management stabilize the ABC, elevate the head of the bed 30. They start dexamethasone, avoid the lumbar puncture. Okay. These are the oncology, what they call comprehensive oncology emergency. May occur at any stage of the cancer evaluation. They maintain a high index of suspicion, timely assessment and target intervention, and multidisciplinary local protocol. These are the ones, the last, febrile neutropenia. Okay. It's most frequent and serious complication of the cancer therapy, especially following the chemotherapy, defined as a fever occurring with the neutropenia, which significantly increases the risk of life-threatening infection, high morbidity and mortality. Prompt recognition and immediate antibiotic therapy is very important to save this patient, defined as absolute neutrophil count less than 500, or expected to be less than 500 within 48 hours. It divided to stratified to high risk and low risk. The high risk profound neutropenia, or the patient is hemodynamically not stable, or he has a picture of pneumonia, or nephritis, leukocytis, or he has central line infection, or he has a transplant or acute leukemia. Okay. Or they can divide. So early risk of assessment is for determined patients, determined treatment of inpatient or outpatient management, and this will guide the empirical antibiotic. Be careful that sometimes the patient, they might have all the sign of infection because they are subtle or absent because they cannot mount the effect of inflammation. Okay, immediately please start the antibiotic as when you detect the fever. Don't wait for the lab. And we start the empirical like tazocine, gentamicin, and then depends on the patient is not stable, can get vancomycin. It should be within 30 minutes. They are more prone to all this infection. Okay, so these two conclude. Pediatric oncology patients are at high risk of developing broad range of the critical illness related to both underlying disease and aging therapy. Early recognition, continuous monitoring, and proactive prevention can including timely ICU support, are essential to improve the outcome and reduce complications. A prompt diagnosis and evidence-based management of the oncology emergency can lead to decrease in mortality and morbidity, reduce treatment interruption, minimize long-term sequelae, and the collaboration between pediatrician, emergency physician, intensivist, and oncologist is vital to ensure rapid intervention and optimal survival and the recovery. With that, thank you so much.
Thank you, Dr. for your nice, extensive presentation. You illustrate a lot of things. I know, even 30 minutes with that cannot be presented. Thank you so much, I appreciate it. We are welcoming the next lecturer, Prof. Ibrahim Al-Alwan. He's a figure in pediatric endocrinology. He's working in King Abdulaziz Medical City in Riyadh. He received his MBBS from King Saud University Hospital, and he's trained in Canada and residency Calgary Hospital with Calgary Hospital Fellowship. We hope that he, if they allow them fasting, if you measure blood sugar down, you are the one responsible.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم بكل خير. Thanks the organizing committee for the invitation. And my presentation is about primary adrenal insufficiency. Okay. Dr. Masood? Thank you. Bismillah ar-Rahman ar-Rahim. So, no, nothing to disclose. My presentation will be covered by 4 points. First point is an introduction to primary adrenal insufficiency. And then I'll talk about pathologies. I categorize them, the etiologies, what are they? And then we'll talk about clinical approach for cases of primary adrenal insufficiency, we end by management of acute adrenal crisis, just for the theme of the conference itself. Sorry. This slide to give you an information on how to differentiate between secondary, tertiary, and primary. The secondary and tertiary adrenal crisis or insufficiency, they lack two issues. They lack hyperpigmentation, and at the same time, they lack problem of potassium. So if you have a normal potassium, if you have somebody with normal, no pigmentation, he either has central, either pituitary or hypothalamus. Where a primary adrenal insufficiency, they have to have always hyperpigmentation. The relation of hyperkalemia, it's not always there, but sometimes, most of the time, hyperkalemia is positive in primary adrenal insufficiency. Thank you so much. Why primary adrenal insufficiency is important? Because it's potentially life-threatening. At the same time, has symptoms with what are non-specific. And most of the time, the diagnosis is missed, be it sepsis, cardiovascular disease, metabolic disorders, and unfortunate, most of these have maybe mild or moderate presentations, not always typical, in the same family, in the same brothers and sisters. The associated features are very important, which you need now to do genetic testing for most of your cases of primary adrenal insufficiency, not to lean only for the clinical diagnosis. What are the causes? The list of causes include congenital causes and include acquired causes. The gland is not formed, hypoplasia, or the gland is formed, it's called hyperplasia, and metabolic, autoimmune, non-genetic, and we may have only one hormone out of the 3 hormones from the adrenal cortex which is affected, either the hydrocortisone or the aldosterones. Okay, first case. This is a 2-month-old, missed because she was born at home. She has ambiguous genitalia with hyperpigmentation, her blood pressure in the high side. And the likely diagnosis is 11 beta, yes. So the commonest cause of congenital adrenal hyperplasia is 21. But the presence of hypertension does not exclude adrenal insufficiency. Yes? Can 11 beta present with adrenal crisis? Yes. And that's the problem with medicine. It's not 1 + 1 is 2. Never. So occasionally, and very rare cases, that an 11 beta may present with adrenal crisis in spite that usually they have hypertension. Okay. Why we call it hyperplasia? In spite that it is a genetic defect of adrenal cortex, because there's continuous drive from the ACTH with the absence of cortisol, leading to the increased size of the adrenal gland. And if we see the adrenal cortex enzymes, we have more than 9 enzymes. Only 5 of them will cause congenital adrenal hyperplasia. And the ones which cause hyperplasia, they have to have the cortisol low. The ones which have normal cortisol will not cause for you hyperplasia. Like this enzyme 18, or the enzyme 17 beta, or aromatase, they are not related to cortisol formation, so they don't cause congenital adrenal hyperplasia. So what are the enzymes? The 5 enzymes. The first one is called STAR. Second one are 3-beta hydroxysteroid. The third one is 17-alpha. The fourth one is the commonest one. It's 21-hydroxylase. And the last one is the one we just showed a minute ago, 11-beta hydroxylase deficiency. When we see hyperplasia, always we have low cortisol on all of the 5 of them. And we may have mineralocorticoid in the high side, causing hypertension, or low side, which is hypotension. In the same case, you may have high androgen affecting only females, or low androgens and causing ambiguity in male only. These are the 5, and if we combine 2 of them, 21 and 17 alpha, we'll have another 6 type of congenital adrenal hyperplasia. Okay, sometimes we say the patient had congenital adrenal hyperplasia 21, but he presented at the age of 6 years, not 3 weeks of age. Why is that? Because of the enzyme activity. When we have the classical form of the 21 hydroxylase, we have 0 enzyme activity. When you have only 2 to 5, we have non-classical. When we have atypical and non-classical, is you have 50% of the enzymes is active. Now we finished the first common cause of primary adrenal insufficiency, which are the congenital adrenal hyperplasia. We move to the second topic, that's just to prove from a large study of primary adrenal insufficiency that the bulk of all primary adrenal insufficiency are congenital adrenal hyperplasia, 21 hydroxylase deficiency. The rest are only 2-3%. What about hypoplasia? The difference are the hypoplasia is a problem of anatomy. You don't form the gland. So that leads to all the 3 hormones on the low side. And we have 6 genes which are important to form the adrenal gland. And if any one of them is abnormal, we'll have one of these list of syndromes. Second case. You have a child who's 7 years old, was healthy, and all of a sudden he starts to lose his ability to stand and has ataxia and stop walking totally. And this is his MRI, sorry, CT scan with contrast. What do you see? وين النيورولوجيست معنا ما في؟ محمد تعرفون كل شيء انتم حق النيورولوجي. طيب. So this is adrenoleukodystrophy, and that's part of metabolic adrenal insufficiency. And we do have more than one type. We have the neonatal one, the childhood one, which is X-linked, and we have these 2 syndromes which are related to cholesterol formation. Knowing that all adrenal cortical hormones originally come from cholesterol. So any synthesis defect of the cholesterol may lead to primary adrenal insufficiency. Last one is mitochondrial disease. We know mitochondria affect all the system. And this special disease, SPL1, in spite that it's metabolic, it also moved to only affecting the cortisol formation. So it goes to another category. This child, I saw him when he was very young. His sister died at the age of 2 years with primary adrenal insufficiency. He had hyperpigmentation, but his potassium always normal. So my category, that potassium is normal without hyperpigmentation, this is central. I saw him 25 years ago. So that time we didn't know what is the underlying disease. And I thought he may be central, but he's not behaving like central. We discovered later on that he had severe repetitive hypoglycemia affecting his mentality. His ACTH was sky high, 2,000 almost. And he had no electrolyte potassium. He, along with 4 cases from Kuwait, was discovered to have what we call familial glucocorticoid deficiency, MC2R gene defect, and that was published. In Al-Ahsa, most of the cases I know from our colleagues have this gene type of familial glucocorticoid deficiency. The problem is, since then I was interested on that type of diseases, and I'm leading a study in the Arab country. We have 107 cases, which is the largest cohort in the world for familial glucocorticoid deficiency. In the world, MC2R is the commonest, but in the Arab world, NNT type is the commonest. Do we care, pediatrician, which one is the common or not? Yes, we do. Then their manifestation is different, and their associated problems is different. That one has cardiomyopathy, this one has congenital nephrotic syndrome, and also neurological problems. So we need to have the genetic type. So these fall under the glucocorticoid deficiency alone. So potassium should be normal, highly pigmented. Their ACTH in thousands. We're talking about 2,000, 3,000. Okay. These are the list of the names of familial glucocorticoid deficiency. And we move to the fourth case, a 5-year-old, previously healthy. Then he showed this abnormality 5 months ago. He had also a sister with the same problem. He had a primary adrenal insufficiency. What do you expect he has? خلي الأونكولوجيست برا نجيب واحد ثاني حق الإمرجنسي. Polyglandular. He had polyglandular. Mucocutaneous candidiasis is the destructive nails, is the common presentation first. Then you have hypopara, and then you have primary adrenal insufficiency. Okay, this is the common. This is the older sister, pigmentation with destructive nails. Primary adrenal insufficiency, autoimmune, as an acquired primary adrenal insufficiency. The autoimmune may be type 1 or type 2 or isolated Addison, and we end the categories by non-genetics and only aldosterone. How many minutes? لا تقولي 2 minutes.
5.
شكرا. طيب. This list or this graph will show you يخوفون والله كل مرة ضرب السماء. This graph show you where is the location of each gene defect and why we do have congenital adrenal, why we have familial glucocorticoid deficiency. And I don't want to go through them all, but the ones which cause only cholesterol problem is that one, NNT, and the one at the receptor level, MRAP and MC2R. The one in pink, the one in pinkish color, is the one which leads to the hyperpigmentation. When we have high ACTH, we break down with it PCOMC, melanocorticoid, at the top of the graph. And that's which leads to the hyperpigmentation, always seen with the primary adrenal insufficiency. Okay. صورة من تركيا اللي يحب التصوير. Now we go to the clinical approach. We have suspicion. If there is suspicion to central, we have a chronic steroid use, especially for the ER colleagues, for the oncology colleagues, for the nephrotics, nephrologists, maybe CNS problems, optic nerve hypoplasia, midline defect, brain tumors, all suggest central, not primary adrenal insufficiency. And they don't have hyperpigmentation, they have normal potassium. The primary one, usually in CH, they come with ambiguous genitalia, and later on have hyperpigmentation, poor gain of weight, and also hypoglycemia. And cortisol is very important for maintaining glucose as a controlled laboratory hormone, especially in fasting. So to confirm the diagnosis, you need cortisol, ACTH, and if you suspect primary, you need to add 17-hydroxyprogesterone to exclude 21-hydroxylase, androgens, electrolytes, plasma renin activity. Normal, you excluded adrenal insufficiency. Abnormal, you have primary adrenal insufficiency. Now we go to what are the issues if it's abnormal, if the cortisol, ACTH is normal, but the electrolytes is abnormal, you think of either renal-related problems or melanocorticoid, either action or resistant. Okay? So we may have hyperkalemia, hyponatremia, hypotension, with the normal ACTH and cortisol, that may lead you to one of these differential diagnoses. If you have the classical one, the primary adrenal insufficiency, we'll have all typical and the differential we gave you before. A big list, but what I want you to know, I want you to do 4 things, or look into 4 things. First one, always think of congenital adrenal plasia 21 because it's the commonest of all. So you do 17 hydroxyprogesterone level, always. And then second test you do very long chain fatty acid to exclude adrenoleukodystrophy, especially if somebody had neurological problems. And then later on, as an acquired, you may do antibodies, adrenal gland antibodies, and you look for the association. There's association or there's absence of association. Okay, crisis, how to manage them. Then the first thing we need as an emergency colleague is to prevent. And from me, my clinic, or colleagues from oncology, nephrology, if somebody is in chronic steroid therapy, he needs to go home with this list. He needs to have that paper with him always. That please, my patient was in steroid for a long time. If he came to the emergency room, please give him so and so. Okay? And we categorize our grade the adrenal crisis to 4. Simple, if you had only cold, temperature less than 38.5, can be managed at home, just double the dose. The hospital needs antibiotics, but the antibiotics for bronchial asthma, for pneumonia, you need to triple the dose for 5 days. But he's in the ICU, or going to the OR, you need to give him emergency. And if you lose them, he will die, and that's grade 4. How to manage? Manage empirically. If he came to the emergency room, you know that he has, before steroids, just give him hydrocortisone. If you don't know, take ACTH, take cortisol, give him hydrocortisone. Be in the safe side. For the shock, 20 cc per kg, the minimum. I was talking to Dr. Osama, أقول له زملائنا حق لي سلم عليه في الطريق يعطيك 10 cc per kg. يعني that's the symbol يعني السلام عليكم. Now start with 20 cc per kg, and you can go up to 60 cc per kg, especially if he is not improving, especially the refractory cases. Hypoglycemia, treat them like any hypoglycemia in the ER, 5 to 10 cc of D10, and then you give the steroid a stress dose, 25, 50, 12 based on the age, and you follow that by 6 hourly divided dose for 1 day. Look for hyperkalemia and treat it. Usually, when you give the steroids and you give the fluids, the hyperkalemia goes down. If it did not go down, you have to treat the hyperkalemia. Okay? It's my presentation. في نكتة على هذه. This is I took this picture from the office of the university. Downtown عني 18 كيلو تقريبا. To see a huge either moon or sun, you need to be far away from the place you are taking the picture from. تقول النكتة ايش؟ إذا أنت من الحسا تفطر في الحسا، تغدى في البقيق، تعشى في العقيق. إذا كنت من الخبر تفطر في الخبر، تعشى بالدمام، وتغدى وين فيه؟ في البحرين. إذا كنت من الرياض تكون في الرياض غدا على طريق خريص. It takes 1 hour and a half minimum for each drive every day. شكرا لاستماعكم.